Good morning. Today, we are going to discuss about parasympathetic nervous system. So, coming to a brief review of the nervous system, we can classify them into central nervous system and peripheral nervous system. And in central nervous system consists of brain, spinal cord, whereas in peripheral nervous system, that is PNS, which includes somatic nervous system and autonomic nervous system. Under autonomic nervous system, we will discuss sympathetic system or adrenergic system and parasympathetic system, otherwise called as cholinergic system. So here we can see the main mechanism involved in parasympathetic system, that is the rest and digest mechanism. If our body produce parasympathetic actions, then the patients or the persons will be in a rest and digestive mode, that is a relaxation mode. So the main neurotransmitter involved in parasympathetic system is acetylcholine, and acetylcholine mediates all the parasympathetic actions. So here we can see the different actions of sympathetic and parasympathetic system on our different body parts. First of all, we will see the pupil, that is the actions of the sympathetic and parasympathetic system on our eye. In sympathetic system, the pupil will dilate, whereas in parasympathetic system, the pupils will be contracted state. And in sympathetic system, the heart rate and heartbeat will rises, and blood pressure rises, force of contractions on the heart rises, and the digestive actions will get suppressed, whereas in liver it will stimulate the release of glucose, and also from the adrenal gland, both adrenaline and noradrenaline will releases. That is, the sympathetic nervous system is involved in a flight or fright response. If we get frightened due to any attack or stimuli, then automatically our body will produce reflex actions. Our heartbeat rises, our pupil will dilate, our digestive actions get suppressed. So, in order to escape from that side, we need glucose. So, our glucose production in the liver rises, the muscle will relax, and the pooling of blood into the peripheral system will increases. Whereas in parasympathetic system, the body is in a digestive or rest state. So our heartbeat, heart rate, everything will be suppressed, and we are in a relaxed mood. So we will need a peep of earth, that is, it will stimulate our digestive actions. So automatically our urination, defecation will increases, and peristaltic movements will also increases. So next, we can discuss the drugs which acts on the cholinergic system, that is the cholinergic agonist. They are the drugs, or they are the agents which have the ability to bind to cholinergic receptors and to produce the actions of the cholinergic system. So we already say that cholinergic system is always called as the parasympathetic system. So based on the mechanism of action, in parasympathetic system, we can classify the drugs into parasympathomimetic drugs and parasympatholytic drugs. So in parasympathomimetic drugs, these are the drugs which binds directly to the cholinergic receptors and produce the actions of this cholinergic system. So they are called the cholinergic agonist, whereas certain drugs which binds to cholinergic receptors, but they are not agonists, they are antagonistic in nature. That is, they will oppose the actions of the cholinergic drugs on these receptors. That is, whatever the mechanism of action of this cholinergic system, these anticholinergic drugs will directly reverse the actions of this system. So, first of all, or in this chapter, we will discuss parasympathomimetics or cholinergic agonist. So, coming to the neurohumoral transmission involved in the synthesis of acetylcholine, as I already said, in parasympathetic system, acetylcholine is a major neurotransmitter involved. So, here we can see the synthesis, storage, release of acetylcholine and the actions of acetylcholine on various receptors. So, yes, here we can see a presynaptic neuron and postsynaptic neuron. And here we can see the synaptic cleft, that is the region or the space between two neurons, and the choline which is taken up by these presynaptic neurons, and in this synaptic neuron it will combine with acetyl-CoA to form acetylcholine. That is, the synthesis of acetylcholine takes place, and further acetylcholine will engulfed or is stored in the certain storage vesicles, and when there is a rise in an action potential, that is during the entry of the calcium into these presynaptic neurons, the exocytosis of this acetylcholine takes place, and the acetylcholine released into this synaptic cleft, and from this released acetylcholine it will bind to the postsynaptic cholinergic receptors, that is muscarinic and nicotinic receptors, and after the binding to these receptors, the acetylcholine will produce the actions of cholinergic system. Whereas in the synaptic cleft, there is an enzyme or called as acetylcholine esterase enzyme. This enzyme have the ability to degrade this acetylcholine again into choline and acetic acid and terminate the actions of acetylcholine. That is, it will metabolize the acetylcholine. Okay. So, here the released, that is the degraded choline is again reuptaken into this presynaptic neuron again, and it will further converted into acetylcholine. So next we can discuss various type of cholinergic receptors. There are two type of receptors are there, muscarinic and nicotinic receptors. In muscarinic receptors, there are four type of muscarinic receptors. They are M1, M2, M3, M4 and M5. So we will discuss in detail the M1, M2, M3 receptors. And regarding the location of these receptors, we can see the M1 receptors mainly seen in our central nervous system and also in gastric glands, and M2 receptors are present mainly in heart, and M3 receptors on various smooth muscles of our lungs, intestine, etc. And M4 and M5 receptors are present in CNS. So coming to the nicotinic receptors, there are NM receptors and NN receptors are there. These NM receptors are present in neuromuscular junction, and these NN receptors are present in the autonomic ganglia and adrenal medulla. So the first M1, M3 and M5, these three receptors are inhibitory in nature. That is, whenever the drugs which binds to these M1 receptors, they have an inhibitory action, whereas M2 and M4 receptors are stimulatory in nature. Okay. So, coming to the parasympathomimetic drugs, we have directly acting and indirectly acting drugs. So, what is directly acting? Directly acting means the drugs which binds directly to these cholinergic receptors. Okay, they are choline esters and alkaloids. And in choline esters, we can see acetylcholine, bethanyl, and carbachol. And in alkaloids, we can see pilocarpine, muscarine, and arecholine. And coming to the indirectly acting one, that is what is meant by indirectly acting. That is, these drugs which binds to anti-choline esterase, and by inhibiting the actions of this choline esterase, these drugs which increases the amount of acetylcholine in the synaptic cleft. And these drugs are reversible and irreversible in nature. What do you mean by reversible? That is, if these drugs which binds to this anticholinesterase, they can be reversible, or their action can be reversible. Whereas the drugs which means irreversible, if they binds to this anticholinesterase, their action cannot be reversed back. So, the reversible anticholinesterases are physostigmine, neostigmine, pyridostigmine, edrophonium, rivastigmine, and donepezil. And in irreversible, there are organophosphorus compounds are there and carbamates are there. Organophosphorus compounds are malathion, parathion, and various nerve gases like sarin, and soman, and carbamates such as carbaryls and propoxyl. And in this reversible anticholinesterase, the physostigmine is there, which is mainly used to reverse effect of anticholinergic drugs. And neostigmine is there. This is the main drug of choice for the treatment of myasthenia gravis. And the edrophonium is used for diagnose the myasthenia gravis. And donepezil and rivastigmine are the drugs which can be used for the treatment of Alzheimer disease. So, first of all, we will discuss about the choline esters. They are acetylcholine, carbachol, and bethanyl. So, acetylcholine, which is a prototype drug, that is acetylcholine, which is hydrophilic in nature, and this drug is not used clinically because if it is taken orally, the drug is rapidly degraded in the gastrointestinal system, rapidly hydrolyzed in our GIT. So, acetylcholine cannot be used clinically. Okay, and it is rapidly degraded by acetylcholine esterase enzyme. So, we know that acetylcholine, which is a parasympathomimetic drug, which is a choline ester, then acetylcholine which binds to both muscarinic and nicotinic receptors, and the acetylcholine can be degraded by acetylcholine esterase, etc. Okay, so next we can see or we can discuss the muscarinic mechanism of action behind the muscarinic receptors. The muscarinic receptors, such as M1, M3, and M5, are G protein coupled receptors. Okay, so in G protein coupled receptors, we know that there are GI and GQ and GS, and these M1, M3, M5 receptors which are directly linked to GQ proteins. So this GQ protein further stimulates the production of phospholipase C, inositol triphosphate, diacylglycerol, and increased amount of calcium. Okay, whereas the M2 and M4 receptors are directly linked to the GPCR receptor GI. GI, as the name indicates, it is inhibitory in nature, and it will further inhibits the adenyl cyclase pathway, and which reduces the cyclic AMP production. That is why we say that these M2, M4 receptors are inhibitory in nature, and M1, M3, M5 are stimulatory in nature. Both of these, all of these receptors are G protein coupled receptors. Even though they are GPCR, the M1, M3, M5 are stimulatory, that is stimulate the cyclic AMP, whereas M2 and M4 inhibits the cyclic AMP pathway. Whereas nicotinic receptors are ligand-gated ion channels, and these ligand-gated ion channels are present on the surface of membranes, and during the influx of sodium ions, if an acetylcholine which binds to this ligand-gated ion channels, the influx of sodium ions out from the outer part to the inner part of the cell. So, due to this movement of the sodium ions into the cell, the depolarization takes place and the action potential generates, and further stimulation of the nicotinic receptors will take place. And we know that acetylcholine, which has both muscarinic and nicotinic action, acetylcholine, which can directly binds to the muscarinic receptors, and also binds to these nicotinic receptors, and they will produce as the cholinergic effects. Okay, that is the mechanism of action of acetylcholine. Next, we can discuss the various muscarinic actions of acetylcholine, which means that the actions of acetylcholine, which is exerted through muscarinic receptors. So, first action on I is, as I already said, that is what meiosis. Okay, acetylcholine, which binds to the receptors, mainly circular muscles of our eye, are innervated by this parasympathetic system, and on the eye, the circular contraction of the circular muscles, and it will causes the meiosis. And in heart, there is M2 receptors, and they will suppress the force of contraction, heart rate, BP, etc. And next is the smooth muscles of lungs, which is innervated by the M3 receptors, and in GIT M3 receptors, and also in urinary bladder innervation by M3 receptors. And in smooth muscles of lungs, they will cause bronchoconstriction, and in GIT they stimulate the secretions, and in urinary bladder they will cause the contraction of the detrusor muscle and relaxation of the sphincters, and in exocrine glands they will stimulate the productions of all glands. Okay, here we can see the action of acetylcholine on eye. Here is the pupil, and here is the, we can see the iris and pupil. Okay, the circular muscles of our eye is innervated by M3 receptors, and behind these radial muscles we can see, behind the circular muscles we can see radial muscles, and which is innervated by adrenal gland receptors or adrenergic receptors. So here we can see a normal eye, whereas in cholinergic system, the acetylcholine will cause the contraction of circular muscles and will leads to meiosis. Whereas in adrenergic system, which will causes the instead of causing contraction of circular muscle, they causes a contraction of radial muscles, and which will leads to mydriatic condition. Okay, and here we can see the anatomy of eye. The first thing we can see on the figure is cornea. Behind the cornea, we can see iris, and in between the iris there is pupil, and behind it there is lens, ciliary body, etc. And the angle between this iris and cornea is called iridocorneal angle, and the the production of aqueous humor is from the ciliary bodies, and this produced aqueous humor is drained into the anterior chamber through this uh, iridocorneal angle. Okay, and these ciliary bodies as well as this iris is innervated by M3 receptors. So the circular muscles of this eye iris causes contraction and spasm of accommodation as well as reduction of intraocular pressure. So due to the increased drainage of aqueous humor due to the meiosis and ciliary muscle contraction, this acetylcholine can be, or this cholinergic drugs can be a choice for the patients who having glaucoma. Okay. Next, we can see the effect of acetylcholine on heart. The heart is innervated by M2 receptors, and binding of acetylcholine on heart will reduces the heart rate, reduces the force of contractions, and reduces the AV nodal conduction. Okay, and in lungs, there are M3 receptors, and due to the actions of these M3 receptors on the lungs, the bronchoconstriction takes place and bronchospasm takes place. Here you can see normal lung and airway, and also an inflamed lung and airway. And coming to the GIT, the acetylcholine will innervate the M3 receptors, and which increases the GIT motility and will cause the colic pain and increases the peristaltic movements, and laxes the sphincters and will facilitate the defecation process. And in urinary bladder, cholinergic drugs which causes the contraction of detrusor muscle and relaxation of the sphincters and will causes the easy defecation. Okay. So in coming to the various glands, acetylcholine which increases the secretions from all glands. Due to this increased secretion, it will causes, or we can see, or we can say the mechanism or the actions of acetylcholine as sludge. That is, a short form is sludge. That is salivation, lacrimation, urination, defecation, gastric and tracheobronchial secretion, etc. So coming to the nicotinic actions, here we can see skeletal muscles. The contraction of skeletal muscle cause is the main mechanism of action of this parasympathetic system. The skeletal muscles are innervated by NM receptors. So these NM receptors and the major neurotransmitter involved here is only acetylcholine. There is no pre and post ganglionic neurotransmitter. There is only one neurotransmitter, that is acetylcholine, and which causes the contractions of skeletal muscles. Okay, so coming to the uses of these choline esters, as I already said, due to a prototype niche, acetylcholine is not used clinically, and we use bethanicol. Clinically, we can use bethanicol, and bethanicol is a beta-methyl ester of acetylcholine. So, due to the presence of this beta-methyl group, this bethanicol is resistant to hydrolysis by acetylcholine esterase, and there are other two drugs. They are carbachol and bethanicol. The carbachol and bethanicol, they are the carbamic acid esters. So due to this carbamic acid nature, they are resistant to hydrolysis by choline esterase. And this acetylcholine has both nicotinic and muscarinic action, but bethanicol have only muscarinic action due to the presence of beta-methyl group. Okay, and in carbachol and bethanicol, the bethanicol can also contain a beta-methyl group, so it has only a muscarinic action. Okay, next, here we can see various conditions and the actions or uses of this choline esters on these conditions. First one is paralytic ileus. That is the condition in which there is a reduction in the GIT motility. So, if we give choline esters on these patients, which will act on the M3 receptors in GIT and increases the motility, which is mainly done after any surgery procedures in order to normalize or in order to increase the motility. Next is post-operative urinary retention. That is, after during any operations, we not need any urination or defecation process, etc. We need the patient in a relaxed state. So after this operation, we need the normal movement of urine and feces from the digestive system. So we can do choline esters. These drugs which causes the contraction of urinary bladder and urethra, detrusor muscle, and improve or facilitate the urination process. And it has the ability to increase the secretions from all glands. So it is a drug of choice for the patients having dry mouth or xerostomia. And these drugs which acts on these M3 receptors of the salivary glands and increases the salivary secretion. So it is a major drug of choice for the xerostomia or dry mouth. So it can be called as hyalagogue. That is the agent which can increase the salivary secretion. So choline esters are hyalagogue in nature. So coming to the major adverse effects of acetylcholine, there are both muscarinic and nicotinic areas are there because of this acetylcholine has the actions on both muscarinic and nicotinic receptors. Okay. So coming to the muscarinic adverse effects, what are they? That is diarrhea, urination. That is their actions are also Even though these are the actions of acetylcholine, sometimes it may be the ADR of this acetylcholine. They are diarrhea, urination, meiosis, bradycardia, that is reducing heart rate, bronchospasm, that is a constriction of bronchial smooth muscles, E4 emesis, that is induces the vomiting, and lacrimation, salivation, sweating, anxiety, distress, and with certain type of colic pain. Colic pain, which means that stones, that is mainly stones in our gallbladder. These stones in gallbladder occurs due to the contractions of our uh, uh, contractions of gallbladder. And necrotic areas are muscle twitching, fasciculations, and general weakness. Okay. Next, so that's all about the colon esters. Then we can discuss the various alkaloids used for producing the cholinergic actions. They are pilocarpine, mescarin, and arecolin. Here we can see the main mechanism of action of pilocarpine. And pilocarpine is a plant-derived derivative obtained from Pilocarpus microphyllus. And this drug is a tertiary amine and which can easily cross the blood-brain barrier. So, instead of pilocarpine, these acetylcholine or any other choline esters, they have quaternary ammonium structure. So, due to this structure, they cannot penetrate CNS and cannot produce any CNS effects. But unlike acetylcholine, pilocarpine is tertiary in nature and can cross the blood-brain barrier easily. Okay, and it has mainly muscarinic action predominated. Okay. And the main ADR of this pilocarpine is pulmonary edema. And all other ADR of acetylcholine can be written as the ADR of pilocarpine. So, here we say the main ADR of the pilocarpine is pulmonary edema. Why this condition caused? What is the reason behind this pulmonary edema? Due to the contractions. Okay, contractions. Next, coming to the uses of pilocarpine. The first use of pilocarpine is for the treatment of glaucoma, that is by reducing the IOP and increasing the drainage of aqueous humor and to the causing of scalar muscle contractions. So it can be given as an occlusert in glaucoma patients, and also we can be given in dry mouth or xerostomia condition because of its sialagogue nature. So coming to another sialagogue, that is cevimeline, which is a new drug selectively acts at the entry receptors in the lacrimal as well as the salivary gland epithelium, and which can increases the secretions. And cevimeline can be considered as a long-lasting sialagogue than pilocarpine. So, and this pilocarpine cannot be used in bronchial asthma or peptic ulcer patients because due to the bronchoconstriction and production of gastric secretions. Okay. Next one is anticholine esterase. That is the agents which binds to this anticholine esterases and thereby increasing the amount of acetylcholine in our cholinergic system. They are reversible and irreversible are there. And reversible we can discuss physostigmine, neostigmine, pyridostigmine, and in irreversible we will discuss about organophosphorus compounds. So the acetylcholine which binds to this muscarinic as well as this nicotinic receptors and will produce the cholinergic effects. And acetylcholine is degraded by acetylcholine esterase into choline and acetic acid. And this acetylcholine esterase is prevented by an enzyme called anticholine esterase. Okay, so coming to the mechanism of action of this anticholine esterases, these agents, their structurally similar to acetylcholine, and these drugs which binds to and inhibit the acetylcholine esterase enzymes. And thereby inhibition, they will increase the level of acetylcholine in the synaptic cleft and produces the cholinergic effects indirectly. Here we can see acetylcholine, degradation of acetylcholine into choline and acetic acid by acetylcholine esterase, and this enzyme is further inhibited by anti-cholic esterase. So, coming to various reversible anticholinesterase, they are physostigmine. This drug, which is tertiary in nature, which can easily cross the blood-brain barrier, and cornea. Okay, physostigmine can easily crosses. And next one is neostigmine and pyridostigmine. These agents have more action on NM receptors. And next is edrophonium. Edrophonium is a short-acting drug, can be used for only the diagnosis of myasthenia gravis. Next is tacrine, donepezil, and rivastigmine. These are the drug of choice for the Alzheimer's disease. They are cerebroselective in nature. So, the uses of reversible anticholinesterases. The first one is physostigmine. This agent can be used for the treatment of glaucoma. Okay. Why this physostigmine can be used in glaucoma patients? Yes, it can reduce the intraocular pressure. Okay, and it can increase the drainage of aqueous humor from the or through the iridocorneal angle into the anterior chamber. Okay, and can be a agent of choice for atropine or belladonna poisoning, since it crosses the blood-brain barrier, so reverses the central and peripheral effects of atropine. And next one is neostigmine. This is the drug of choice for myasthenia gravis, curare poisoning, cobra bite, and paralytic ileus. Why this agent can be used for these four conditions? Because neostigmine can cause the contractions of skeletal muscles. In curare poisoning as well as in cobra bite, there is a persistent depolarization of our skeletal muscles due to these toxins. So this when in these patients neostigmine is given, this agent will cause skeletal muscle contractions. And in paralytic ileus, neostigmine increases the motility and peristalsis of GIT. That is curare poisoning. From this curare, we can obtain a drug called D-tubocurare, which is an arrow poison it is obtained from a plant Strychnus Nux vomica, and which can inhibit the NM receptors in skeletal muscles and will cause the skeletal muscle paralysis. Okay, persistent paralysis. Here we can see a paralyzed patient which do not have the ability to contract his muscles, skeletal muscles. So in this patient, if we given neostigmine, it will inhibit the NM receptors in skeletal muscle, whereas it increases the acetylcholine amount in this neuromuscular junction and will cause the skeletal muscle contraction. Okay. Here we can see the cobra-bited patient. Next, coming to the use of neostigmine, we said that myasthenia gravis. This is a disease condition. Mainly, it is an autoimmune disorder. In this disease condition, the autoantibodies are formed against the NM receptors in the neuromuscular junction. And the various symptoms of myasthenia are eye drooping of one or both eyelids, double vision, face and throat muscle laxation, altered speaking, difficulty in swallowing, problems in chewing, limited facial expressions, neck lymph muscle weakness, etc. So, the drug of choice, main drug of choice is neostigmine tablet, 15 mg, 3 or 4 times daily orally. And alternative to neostigmine, there are pyridostigmine is there, and pyridostigmine is a long-acting drug. And the rationale of neostigmine in myasthenia gravis, that is, Neostigmine can be used in myasthenia, and the neostigmine can act in two ways, that is, directly and indirectly. Here we can say neuromuscular junction, and there are NM receptors are there. Already there are antibodies against this NM receptors are produced in this NMJ. Neostigmine can directly stimulate the production of acetylcholine, and by or through the action of this acetylcholine, it will increases the influx of sodium ion into the cell and will causes the depolarization and contraction of these skeletal muscles. Okay, that is indirect action by indirect stimulating the production of acetylcholine, and it can also act in a direct way. That is, neostigmine directly increases the sodium influx into the NMJ and will causes the depolarization and contraction. Okay. Next, the other drug of choice for myasthenia patients, since it is an autoimmune disorder, so we can give glucocorticoids or another immunosuppressants to the patients. And these immunosuppressants can inhibit the production of various antibodies to NM receptors. That is the rationale behind using immunosuppressants in autoimmune patients. Next one is thymectomy. Thymectomy is the removal of thymus gland from the patient. Thymus is, we know that thymus is the main organ involved in the production of various antibodies in our body. So removal of thymectomy is also a remedy. And also for diagnosing myasthenia, we have hydrophonia. And hydrophonia can be used for differentiate whether a patient has cholinergic crisis or myasthenic crisis. We know that even though this acetylcholine will cause the contraction of skeletal muscle, an increased amount of acetylcholine or produce a marked elevation of acetylcholine in this neuromuscular junction will causes persistent depolarization, and it will also causes myasthenia or skeletal muscle weakness. Whereas in myasthenic crisis, this crisis occurs due to the production of antibodies against its NM receptors on the neuromuscular junction, and it also causes skeletal muscle paralysis. So, if we give hydrophonium to the myasthenic patient, if the patient improves due to the production of increased amount of acetylcholine in the neuromuscular junction by the action of hydrophonium, which means that the patient is suffering from myasthenic crisis, and if even after giving the hydrophonium to the patient will not improve, which means that the patient is suffering from cholinergic crisis, because due to the action of hydrophonium there is an increase, again an elevation in the acetylcholine level in the neuromuscular junction. It will further worsen the cholinergic crisis. So, coming to Alzheimer's disease, what is Alzheimer's disease? We know that is a memory impairment disease, and Alzheimer's disease is actually the degeneration of our cortex, thalamic cortex degeneration due to the accumulation of certain beta amyloid plaques. Due to their accumulation, the amount of acetylcholine level in our brain will or in our cortex will reduces. So, in Alzheimer's disease, reversibly acting anticholinesterase is a drug of choice. They are tackling donepezil, rivastigmine, and galantamine. So, next we can discuss the or we can compare the physostigmine and neostigmine. The various source of physostigmine is a natural alkaloid, Physostigma venenosum plant, whereas neostigmine purely a synthetic drug. And coming to the chemistry, physostigmine, which is a tertiary amine, whereas neostigmine, which is a quaternary compound. And coming to mechanism of action, both these agents which inhibits acetylcholine esterase enzyme, and physostigmine, due to the tertiary nature, it can better penetrate in CNS, whereas neostigmine cannot penetrate CNS due to its quaternary action or quaternary structure. And the physostigmine has good corneal penetration, so drug of choice for glaucoma, but neostigmine Whereas in case of neostigmine, the corneal penetration is very poor. And coming to the physostigmine, they have no direct action on the neuromuscular or NM receptors. Whereas neostigmine, which has more effect on skeletal muscles and has a direct effect on this NM receptors. And the preferred use of this physostigmine is glaucoma and atropine poisoning, whereas neostigmine, the preferred use is myasthenia gravis, cobra, bite curare poisoning, etc. Okay, so we can discuss certain questions regarding this portion. Various subtypes of muscarinic receptors. We know that M1, M2, M3, M4, and M5 are there. And nicotinic receptors are which type of receptors? They are NM and NN receptors, and they are ligand gated ion channels receptors. And acetylcholine is not used clinically. Why? Because which is more prone to acetylcholine esterase degradation. Okay. Next, long-acting Cialago, we have pilocarpine and cevimeline, but cevimeline has more action on muscarinic receptors and other glands. So, long-acting Cialago gives cevimeline. And next is the drug of choice for myasthenia gravis. Yes, we have neostigmine, pyridostigmine, and the drugs for Alzheimer's disease, donepezil, tacrine, rivastigmine, galantamine, etc. And next question, acetylcholine is metabolized by dash enzyme, that is cholinesterase enzyme. And next one is the muscarinic receptor present on myocardium. We know that M2 receptors. And the one use of pilocarpine is glaucoma. And coming to next question, mention for ADR of choline esters. Yes, we know that choline esters which increases the secretion, salivation, lacrimation, urination, defecation, etc. Okay, that's about reversible anticholinesterases and directly acting cholinergic drugs. Next, we can discuss irreversible anticholinesterase compounds. They are organophosphorus compounds. They are very dangerous compounds, and these OP compounds are not used clinically. They have only a toxicological importance. They are used only as insecticides or pesticides. So, what is OP poisoning? That is, if we consume excessive amount of organophosphorus compounds, it will inhibit the acetylcholinesterase enzyme in our body. Due to the inhibition of this acetylcholinesterase, profound increase in acetylcholine level in the neuromuscular junction takes place. Okay, so due to this profound effect of acetylcholine, it will further causes respiratory paralysis, tremor, convulsions, etc. And this OP poisoning can cause suicidal, accidental, and homicidal. That is, maybe OP compounds consumed by the patients by accidentally or intentionally. That is, for the suicidal purpose, or for homicidal purpose, it can enter into the body. So the main symptoms of OP poisoning are muscarinic and nicotinic symptoms. That is due to the inhibition of this cholinesterase enzyme. Okay. So coming to the muscarinic and nicotinic symptoms of OP poisoning. In muscarinic symptoms, we know that the all ACH actions are there. That is lacrimation, salivation, sweating, and pinpoint pupil, blurring of vision, breathlessness, colic, defecation, urination, etc. And in nicotinic symptoms, increased acetylcholine level in neuromuscular junction will causes muscle fasciculations, weakness, respiratory center paralysis, convulsions, coma, and ultimately death. So coming to the management of OP poisoning, we have general measures and specific measures. And for general measures, we can, for the termination of the further exposure to poison, we can wash our hands with soap and water, and proper gastric lavage is necessary. And also maintain the patient airway, breathing as well as circulation. And specific measures, the first drug of choice is atropine. Atropine is an anticholinergic drug which can inhibit the actions of acetylcholine on these muscarinic receptors, but it cannot reverse the peripheral muscle paralysis. Okay, and this which is a competitive blocker of muscarinic receptors, and the dose is 2 mg IV repeatedly every 10 minutes till the patient pupil dilates. Next drug of choice is called esterase reactivators, that is oximes. They are pralidoxames. These agents are otherwise called enzyme reactivators. That is, these agents, when binds to this anticholine esterase, they will reactivate the cholinesterase enzyme, thereby reduces the amount of acetylcholine in the neuromuscular junction. Okay, that's all about parasympathomimetics. Thank you.